Hi, Shanna here. Just want to let you know that Karen and I are going to be going over the 10 actual questions that we posted for free. I thought that in addition to actually having a question written out with the rationale and the correct answer, what better way to learn than to actually have a discussion about it? So I hope you enjoy this. Give us our feedback. And if there's any areas that you want us to discuss more, please send us a message and we'll be happy to do that too. All right? Happy learning. So today, Karen and I are going to go over some of the questions, but actually we're going to do one question at a time. And today, yes, what question did you want to do, Karen?
Let's do 4. You want to do 4?
That sounds good. So if you go on the website, you'll see that we have 10 free questions, and which also provide the answer with rationale. We're just going to kind of go into a little bit more depth on these questions. So question number 4, I'm just going to read to you here. It says, patient is admitted to the progressive care unit with dilated cardiomyopathy. He's anxious, short of breath, his respiratory rate is 28, he's got crackles in his bases, he's positive JVD, 2+ pedal edema. On the monitor, it's showing us that his rate is around 100, he's sinus tach, but he's having frequent PVCs and PACs. Currently, his SATs are 91%, and that's on 6 liters nasal prong. BP is 89/49 with a MAP of 60. And the MD has ordered a dobutamine drip infusion to be started at 5 mics per kg a minute. So the question is, in addition to this, an additional treatment for this patient would include, and then you have your 4 choices there. So hopefully you have this pulled up, because we're not going to go over the 4, but we're just going to start with what the right answer is first, and then we'll discuss the other 4.
Great.
Is that fine?
That sounds good. Yeah. Okay, good.
All right.
So what do you think of this patient?
Well, when I understand why they'd want to start dobutamine,
right?
I think, but I know that the other options here. So I guess we do have to go over kind of what the other. Okay, so I'm going to start something over.
Okay.
Okay.
And then
because then like they should know. Oh, I know what
they're
you're
going
saying.
to have it in the
have it.
Yes, that's
good. I won't have to say it.
Yeah, I think. I don't know. You
no,
think so?
That'll work. Okay, we'll just continue on. Okay, so I see the 4 options there, and then the correct one, I don't know, what do you think? How should we talk about this?
So, typical question, this is a typical question you might get on the
okay.
exam.
Oh yeah, okay, let's start.
And so we got 4 choices.
Yes.
So what do you do with your 4 choices? And there's some pretty important information in the actual question itself. And if you look at that, they're describing a patient who's in heart failure, right?
Yes, yeah.
And their heart failure is resulting in some pulmonary edema even.
Oh yeah,
they've got crackles, right?
Yep.
Positive JVD and crackles.
Mm-hmm.
So you have a patient who has like cardiac problems, but respiratory problems too.
Yeah.
So we got to tackle both of those things. And then also another really key part of this is that you have a patient with low blood pressure.
Yeah, I saw that. And a MAP of 60 isn't something that we want,
for too long.
For too long, no. Especially if we want to get to our goal of 65. But so, I mean, that's kind of hard, because if you think about, we want to start dobutamine, but what does dobutamine actually do? What's it going to do to those numbers?
So if we start dobutamine first, which is kind of essential here, because we need to get the contractility up, and we need to get the dobutamine actually vasodilates too, so it will drop the afterload a little bit for the patient.
If we drop the afterload, then we're going to drop the blood pressure.
It's potentially a little bit. Hopefully you'll have enough cardiac output from the contractility part of the dobutamine too, so we should be okay. We definitely want to do that before we give diuretics or anything to drop his preload or any of that. We definitely got to get that heart pumping a little better. I kind of defend the blood pressure first.
Yeah. Okay, so that makes sense. So before we give them diuretics, because we would consider diuretics because obviously the positive JVD and the crackles tell us that his preload is high.
Right. Exactly.
So he's needs to pull some of this fluid off, and then obviously with 2+ edema, that also talks about how much fluid he has on him that we probably should get off. But I see your point, because that if we diurese him first, then that blood pressure will all come down because we're
It's a
getting rid of that fluid.
possibility. Yeah.
So I see. So the best thing would be to start a drip first before we consider diuresing them.
Get the dobutamine on board, and then you're gonna have to get the fluid off. And he has like right-sided heart failure. You're seeing signs and symptoms of that, and also left-sided heart failure. So and that's really common in cardiomyopathy, where both ventricles are not contracting really well.
Okay.
So I like to think in cardiomyopathy, the patient has like a basketball heart. It's really dilated out, so they don't have very good systolic function. They can't pump blood out very well.
Okay.
Heart can be pretty full, but it's really hard to get it out.
Get it out. Okay.
Yeah.
So we're supporting it to be able with dobutamine to be able to get it out.
Yeah.
First.
Yeah.
Okay.
Yeah.
So I know 1 is the answer.
1 is the answer.
Yes.
Exactly.
So it talks about nitroglycerin. So what are we thinking, or what is nitroglycerin doing for our patients? So I know we start the dobutamine before we give them diuretics, so we don't lose the preload, and we don't drop their pressures more.
Yeah.
Followed by diuretics, so now we can start pulling off some of that fluid there.
Right.
And then nitroglycerin, what's that doing for our
So
patients?
that's going to be like a preload reducer. So it's going to reduce the preload, pool some of the blood in the periphery, so that not so much blood is coming back to this over-dilated heart that's in failure. And so it's just going to keep fluid from, there being too much fluid in the right heart. And then if you give nitro also, as the doses go up a little bit, it actually can be a afterload reducer too.
Oh, okay.
Yeah, so it can do a little bit of both.
Okay, so overall, basically, like, we're taking some of the work off of the heart.
Yeah.
By preventing all that fluid from coming back so quickly.
Right. And then making it a little easier for the left side to pump if we reduce the afterload a little bit.
Okay, that makes perfect sense. And this also says start BiPAP and treat his shortness of breath and hypoxemia.
Right.
So does BiPAP affect preload, afterload, or anything like that? I've had people ask me before, like, oh, you put the BiPAP on and, say that the pressure that we support them with can affect their cardiac output. Would we see it in this case?
You can. You really can, Shannon, because anytime you add positive pressure ventilation, and particularly PEEP in addition, in positive index expiratory pressure, now air is taking up the space where the heart could be.
Okay.
And so sometimes any kind of positive pressure ventilation can drop your mean arterial pressure and your cardiac output, but probably not too badly with the BiPAP because of their lower pressures generally.
Yeah.
So usually, I think we're going to be okay in this patient's case. Plus, this is going to add that pressure to the lungs, and it's going to increase oxygenation because we're going to be able to recruit some alveoli that we didn't have before.
And I think that's more of my experience when I hear people talk about, like, oh, what is that pressure going to do on cardiac output? It's like, immediately I see a change in their oxygenation before I see like this tremendous change in blood pressure or cardiac output or something like that.
I think that's really true, and that's important because as their oxygenation improves, the whole situation is going to improve, and so it improves for the patient. So, and another question is, well, why not just intubate this patient?
Yeah.
And maybe some would, but if we could do some of these initial therapies, he could avoid an intubation, and maybe he doesn't want to be intubated. We don't even know that. It's not in the question.
That's true. And I do know that at my facility, like, we try to do everything we can before we intubate the patient. Okay, well, to me that totally makes sense. And when we go through the rest of the questions, we kind of already touched on those. And we were briefly talking about earlier today about non-rebreathers. Non-rebreather masks.
Yes, they're kind of falling out of vogue, if you want to say that.
Yes.
I noticed we don't go to those as often, and I think that's probably a very good thing, because we have better tools. We have BiPAP. Yes. We have high flow O2.
Yes, we use a lot of high flow O2.
Yes.
And I find that's, it feels like we cut out one of those middle steps of using a non-rebreather that
Yes.
really didn't do anything
Right.
for the patient anyways. And then for the people who forgot to fill up the little bag.
Exactly. And I always would say to nurses, if I saw someone on a non-rebreather, I don't care if they're in the ICU, the ED, or the PCU, I always think of them as the sickest patient in the hospital.
Of course, they're the ones that are like right on that tip brink, and you're like, oh no.
Oh, are we going to intubate or not?
Yes. Yep, they are
so I'm much happier when they're on like BiPAP or high flow O2, and their work of breathing's decreased. They look more comfortable.
Yes.
It's
really
just
great.
a much better kind of therapy for them.
Yeah.
Yeah.
And then just one thing. So on number 4, it talks about using lidocaine to control the arrhythmias.
Yeah.
So is this the type of patient that would need lidocaine for arrhythmias? I mean, it did talk about PVCs and PACs.
Yeah.
But is that, do we use lidocaine ever for just PVCs and PACs?
Not usually anymore. It used to be kind of the go-to drug, but no. And in cardiomyopathy patients, it's so common that they will have a lot of arrhythmias. And sometimes you look at the monitor and you think like every QRS looks a different shape.
Mm-hmm.
And that's really common.
Okay.
And so you don't want to treat an arrhythmia that's kind of their norm.
Yeah.
But if you were to see runs of ventricular tach or something like that, you would rule out the causes, like is the patient acidotic or they hypoxic or some of those other things that would be a possibility, but you probably wouldn't want to add an antiarrhythmic in this situation. There's so much going on with this cardiomyopathy patient that antiarrhythmics can become pro-arrhythmic.
Yeah.
And then you have more problems.
Yeah.
Yeah, you don't want any more
No,
problems.
you don't want any more problems
for one day here. Yes.
Well, thank you so much. I hope that helps you guys. I know like discussing the questions actually helps me think out loud, and being able to ask Karen personally like some of the things like about the non-rebreather and BiPAP. This helps me kind of like pull the whole picture together. So please check out the other questions, okay? Thanks.